This is John Fanikos, who is director of the pharmacy at Brigham and Women's Hospital, an anticoagulation expert, and a board member of NATF.
So why don't we get started then? That sounds... So I'll refute the comment of being an expert because I am not. I will say that I have worked with our thrombosis research group for the better part of 25 years. I have worked with our North American Thrombosis Forum, as Catherine has suggested. I have been one of the board members since its inception, or close to it. And while I have an extreme interest in thrombosis, both deep vein thrombosis and pulmonary embolism, as well as the prevention of stroke and systemic embolism in atrial fibrillation, and other conditions like myocardial infarction. As much of the time that I've spent here, every time I have an opportunity to interact with other clinicians, physicians, nurses, pharmacists, whenever I have an opportunity to interact with patients, I recognize how little I know in this world of thrombosis management. And I think that's why we have programs like this tonight, for patients and their family, as well as other clinicians, to listen to some short contemporary discussions or topics, and then open the floor for discussion. Because, like I said, I learn as much from the participants that are present at these events as I do in terms of presenting. So, and the last thing is Catherine probably couldn't find anybody to fit this Monday night 7 p.m. slot, so that's probably why I got the invite. So I'm quite humble in what we do. So I know everybody's on mute, and there's an opportunity to enter the chat box should be on the right-hand side of your screen, and provide questions for Catherine to field. I think at some point we'll open up the audio connections as well and allow people to weigh in on with their questions. So again, my name is John Fanikos. I'm a pharmacist at Brigham and Women's Hospital. Welcome to tonight's program, and welcome to the North American Thrombosis Forum. So I was asked to put together a discussion, and I thought it would be a good topic to touch upon recent trends in anticoagulation research and what this data or what this information means for patients. I didn't even get a couple of minutes in, and my beeper is already going off. So that's good news. I'm with you folks, so I can't be bothered. So here's my outline for tonight. And I wanted to talk about this emergence of, quote, real-world studies. What are they, and why have they come about? Okay. I'd like to compare them and talk a little bit about the differences to randomized trials, the so-called phase 3 randomized double-blind controlled trials that we typically carry out here at our hospital to determine whether a drug is safe and effective. And then I'll hopefully give you a couple examples of studies that are out there. And then I'll summarize, and then hopefully we'll have about 30 minutes of conversation. So I don't have many slides. I think I put together about 30 slides for tonight, and as always, I try to put in pictures, but that's my intent and that's my outline. So let's talk about real-world studies for a moment if we can, okay? And I hope as patients that you do have some links into the medical hot topic electronic news bulletins that come across, for physicians and nurses and pharmacists. There's organizations like Medscape and the Heart.org, First Word. There's a number of what I would call news sources for those of us that are in healthcare. And I hope that you use some of those or have access to some of those. Some of are sponsored by our vendors that provide us with the drugs that we currently use, sometimes by the devices. But there are a number of alerting services that provide information, as does the Boston Globe, the Wall Street Journal, the New York Times, etc. And I can't help but notice that in the last year, we've had lots and lots of what I would call real-world studies emerge surrounding the novel oral anticoagulants that we use routinely in the setting of atrial fibrillation, venous thromboembolism, treatment and prevention, and hopefully soon to be other indications. So the drugs we're talking about are typically apixaban, dabigatran, edoxaban, and rivaroxaban, and I put them in alphabetical order so that there's no bias. And so in this slide, what I depict to you is a number of studies that have emerged in all kinds of settings, whether it's journals like Circulation or JAMA, the Journal of the American Medical Association, the American Journal of Medicine, the American Journal of Cardiology, Circulation. I think you can't help but pick up a medical journal and find an article that talks about real-world studies. And typically, they talk about the things that we try to research here, which is the endpoints of both efficacy. Do we prevent these events from occurring? And then safety. Obviously, with anticoagulants, you worry about the events of major and minor bleeding episodes. And so a number of these studies now have looked at how well these newer drugs compare to warfarin. And now, as we have started to see more experience with those drugs, we're starting to see them compared against each other. Okay, so comparisons against older drugs like warfarin, comparisons amongst the newer drugs that we routinely prescribe. Okay, and because I was recently at the American College of Cardiology meeting in Washington, D.C. in early March, I depict this slide. If you think these studies are a flash in the pan or a shooting star that burns up very quickly, I can assure you they are not. And here are a whole host of real-world data analyses that surround the drug apixaban. These are all real-world trials, and you can look through the different types of studies that have emerged. And these are just the ones that were done here in the United States. There were a whole host of presentations that were done across Europe and the United Kingdom. And my point here is as patients and as clinicians, we are at some point going to have to come to grips with this real-world data and these analyses, and then how do we incorporate them into our day-to-day activities? So what's real-world, okay? And I pulled out a couple of definitions because unfortunately, you can go to lots of different medical journals and lots of different news sources, and you'll find that there's a lot of different varying definitions of what a real-world study is and what real-world data represents. The International Society for Pharmacoeconomics and Outcomes Research, ISHPOR, and they meet typically once a year in Washington, D.C., defines those real-world studies as anything that goes beyond what is normally collected in phase 3 clinical trial programs in terms of efficacy. So most of you should be familiar with the fact that when we test a new drug, we typically look for at least 2 studies that have proven to be successful in those patients with the underlying disease or comorbidity or complication to show that they work and that they're safe for patients to take. And typically, the Food and Drug Administration of the United States grants approval for physicians to prescribe those drugs in routine practice and the vendors to sell them to us in different providers, pharmacies in the community or pharmacies in the hospital. But typically, phase 3 trials are the gold standard. So real world represents anything that is outside of that. I think a more important definition is this one that came from Health Policy, the journal that I've listed below is that they are a measure in understanding healthcare data collected under real-life practice circumstances. And so what we're really talking about are studies or observational data collection that has occurred in the routine delivery of care for patients in whatever setting you choose, whether it's in the hospital, whether it's in an office practice, whether it's in a clinic, whether it's in a procedural area, but information that we are collecting that represents what happens in routine care. Okay, and at the payer level, so you will, and I haven't covered much of it tonight, but you'll see there are lots and lots of studies now that have attached a dollar amount to these treatment strategies, because of course everybody wants to know if you use a strategy that it's expensive, and what drug isn't today, do you actually get your money back, or do you capture value in terms of its delivery? And so from an insurance perspective, anything that is not interventional or research-based is what they are looking at. So real world typically defines what's happening in routine practice. Now, why has there been an explosion? You saw the number of trials that were presented at the ACC meeting. Well, I think what you're seeing is the fruition, if you will, of work that was done by the Obama administration. So you may recall the American Recovery and Reinvestment Act of 2009, and I've provided some details here if you're not a politician or a historical buff. But the primary objective of this act was to save existing jobs and create new ones as soon as possible, given that the country had slipped into a recession. And so there were relief programs as part of this Reinvestment Act. And as no surprise, there was a huge investment in the infrastructure surrounding healthcare. And you can see that the economics, there was billions of dollars, and because I have children in college, I can appreciate the term billion if you're paying tuitions, and I hope many of you are. But there was about $1.1 billion allocated for this concept of comparative effectiveness research. Okay, what I'm describing tonight is real-world studies. So the government, as part of their Patient Protection and Affordable Care Act, established this permanent entity called Patient-Centered Outcomes. The Research Institute, or what we typically call PCORI, that is intended to guide, Department of Health and Human Services, that is intended to guide these comparative effectiveness research programs. And then there was $1.26 billion associated, again, to be provided by this institute between 2010 and 2019. So we're in 2017 now, and I think what you're seeing is first, again, the dollars that supported these programs, but more importantly, the infrastructure and the experience of having between 2010 to 2017, the success of those programs now has mushroomed into more research going forward. So I think if we point to anybody, we can thank the government for the introduction of these programs. Now, why the push for real-life data or comparative effectiveness analyses? And I'll show you some examples as we go forward. And I mentioned the randomized controlled trials that we do here, and they are typically recognized as the gold standard for establishing safety and efficacy. But they operate, and we carry them out in an ideal environment. And Brigham and Women's is a very good example, where we have an infrastructure to support research. We have the tools to carry out all of the laboratory tests and exams that may be necessary to support the research. We have an infrastructure of nurses and pharmacists and physicians to carry out those trials. And then finally, and the most important thing for those of you that are on the phone is we typically have a very captive audience and patients that come to us, with complications of disease or comorbidities that allow us to enroll them in clinical trials and find out if these drugs work. So it is, and has been described frequently as a sterile type of environment, okay? Real-life data is generally not included in many of the randomized control trials. And so we may not have insight into epidemiology. We may not have insight into what is typically carried out in terms of healthcare delivery in a physician's office or in a small community hospital or in a rural setting or in areas where healthcare may not be as easily accessible. Okay, so our clinical trials don't always provide all the information that we need. And despite that, I think what you'll find is most healthcare delivery to patients, certainly in the United States, is not done at academic medical centers, but it's in those urgent care centers, the physicians' practices, that where most of the care is delivered, and that's really where our decision makers reside. And certainly insurance companies that pay for the bulk of that care want to know what is being delivered in a small office or a small community hospital or an urgent care center actually plays out to what has been seen in a randomized controlled trial in a major academic medical center. So there's an interest on behalf of the payers. You may recognize that many countries outside of the United States provide universal health care for their citizens, and so there are a huge number of countries like the United Kingdom, areas like Denmark and Sweden that have, and across Europe where basically the government is providing for the provision of health care, and so they want to know that the standard therapies or new treatments that they're providing in comparison to standard therapies provide advantages for patients, and it's worth the value. So there is a value proposition here. And in fact, some countries now are using this real-life data for the pricing of what they'll pay for new treatments as they're introduced into the marketplace. So the randomized control trials are only one piece of it. There is an interest now in this real-life information to show that as patients progress, their treatments are going to be successful. Now, where do we get real-life data from? And I'll show you a couple of sources. But you shouldn't be surprised that there's databases everywhere. If you go into your supermarket and you buy groceries, they're all barcode scanned. All that information about what you've purchased as an individual, what has been sold by the store, circles back to vendors. So it's not only healthcare, but there are lots and lots of databases across all kinds of walks of life. We have become better now at using these databases in terms of healthcare. Okay, there's patient and population surveys that are available. The government obviously pays out, and Social Security. They want to keep track of information surrounding your longevity as a citizen of the United States, and so there's population-based sources of information. We have information in the medical record, so it doesn't make a difference whether you're seen here at the hospital, whether you go see your local dentist or your local primary care provider. There is typically information. More and more of that information now has become available in electronic format, and in the electronic format, we can capture a lot more information, analyze it, and provide inferences from the information that we have. There are observational studies. We'll talk a little bit about those. There's pragmatic clinical trials, and these are open to debate, in which they raise questions about how things are done in the real-life setting and whether they actually mimic, what should happen in most patients. And then finally, there's registries, and we've been active participants here at Brigham and Women's Hospital and NATF in setting up registries for both patients with atrial fibrillation, our Garfield registry for venous thromboembolism. We did the DVT-free registry for many, many years here at the hospital. And the point is as patients are treated and diagnosed with disease, we keep longitudinal information about their treatment over their lifespan, and it provides us with an important information about not only the treatments that we deliver, but in terms of what benefits patients over the long term. So the registries become an important part of the way they deliver care. So I think what my point here is there's lots and lots of real-life data that emerges in all kinds of different settings, and we are not unique in the healthcare industry. We are starting to harness a lot of that information and use it to our advantage in terms of analyzing it and looking at patient outcomes. So how does this differ from randomized trials? So what information do we get from those sources, and where do we get it from? Well, here I mentioned the structure of randomized controlled trials, and this is a flow chart of the time and events. So if you had suffered a deep vein thrombosis or pulmonary embolism and you were randomized into one of the studies that looked at the new oral anticoagulants, you would find that there is a very rigorous time sequence of events that occurs beginning with screening when you're diagnosed, to a series of baseline tests, and then a series of subsequent visits that typically occurred every 2 months up to a 4-month period, and then once every 4 months thereafter. And there was a whole series of structured questionnaires and tests, laboratory tests, and surveillance for both return of blood clotting events and bleeding events. And so my point to this is that you would not normally see this if you suffered a blood clot and went to your primary care doctor. He may have some early visits and then tell you to come back less frequently, certainly, than what we would do for follow-up in a randomized controlled trial. So the surveillance in the setting of a randomized controlled trial is certainly much more structured than what you would see at a doctor's office or an urgent care center or in an ambulatory clinic. This table is from an article I wrote with Paul Dobish, a pharmacist down in Nebraska. It was published a couple of years ago. And what we try to do for the reader is highlight what was required in terms of entering any one of the trials of the novel anticoagulants in venous thromboembolism. And I think what I want to point out here is that there were inclusion criteria in order for you to get into the trial. There was a strict definition of the efficacy endpoints, and we were measuring recurrent disease, and so there were definitions as to whether you had a blood clot present, and then whether it reoccurred, and that had to be done through testing, either CT scanning or ultrasonography, to diagnose you. And then there were a number of patients who died during the study, and the question was that related to venous thromboembolism, a pulmonary embolic event, or was it something else? The point of this is to just tell you that everything is structured in terms of how we diagnosed you with a blood clot, and then there was certainly a rigorous definition of if you had a recurrent event in terms of enrollment in the study. So very, very strict criteria in order for you to hit one of the endpoints in this trial. Okay, and one more page. There were lots and lots of information. This is only a partial list of some of the comorbidities and complications that were captured as part of a patient enrollment. And I've got them listed here from renal function to hypertension to hepatic function to definitions of bleeding. I'll point out here, which as a pharmacist I think is extremely important, if you took more than 100 milligrams of aspirin a day in several of these trials, you were not included or not allowed to be treated in the trial. There was exclusion criteria surrounding antiplatelet drugs that we commonly use in acute coronary syndromes and anti-inflammatory drugs, and then a whole host of drugs that we think may interact with the novel anticoagulants. So why do I put this up here? Well, it just shows you that one, in the prior slide, lots of criteria for you to get into the trial, lots of criteria for you to reach an endpoint in the trial, and then we collected lots and lots of information about your comorbidities and the severity of those comorbidities, and then we collected lots and lots of information about the concurrent drugs that you were taking as part of your treatment plan, okay? So lots and lots of information as we go forward, okay? Now, if you come to our hospital, this depicts patient care, this graphic here, and patient management. And what it's intended to do on the left-hand side is you typically are scheduled. We verify you when you arrive. We see you in our clinic or we do our procedure. And then the following box, we document everything we do in your medical record. Okay. When we discharge you from the hospital or from your visit, your record typically goes to our billing management division, and they go through with a fine-tooth comb to look and see if they can find more information about the treatments that were delivered to you during your encounter, and they use codes for those interventions. We put all that and wrap it all up into a record, and then we send it off to the insurance company for reimbursement. And you'll see in the boxes to the right, again, medical coding by our folks in medical records. We capture demographics, the charges. We send a claim off to the insurance company, and then hopefully they look at the claim that we've submitted and we receive some sort of reimbursement. And there's always an exchange of information with the insurance companies in terms of the care that's provided. There's rejections and denials. But I think what's most important in all of this is this concept of medical coding. And just to make it a little bit more complicated, I pulled this out from the Journal of Education and Health Promotion. And I don't intend you to read this, but the start button is the medical record, if it will, after your encounter, going to our medical records division and all the steps that are required to finalize your record before it is sent to the insurance company. So this is not for the weak of heart. Okay, there's computer-based programs that are part of this that helps identify or select codes to fit you in a specific category based on your illness. And all of this moves through its sequences before a final bill is submitted to the insurance company. So again, a pretty complex process that goes on in a back room behind the scenes and may not be obvious to you. Okay, and this is where our ability to do real-world studies comes in. So this is a graphic that was presented or part of a publication that we did a few years ago, and we used the example of the Food and Drug Administration's project called the Mini Sentinel Project, Sentinel Initiative. So this is the FDA's post-marketing surveillance program. And so what they are hoping to do is that as drugs are approved, they want to ensure that there's value both on the efficacy side and value on the safety side of patients going forward. And if you let me walk you through this diagram, again, this is a project that resides with the Food and Drug Administration. They typically have questions about the efficacy or safety of a product. There are a number of data coordinating centers that are present in the United States. We actually have one here at Brigham and Women's Hospital. And so those data coordinating centers can go through a portal, a computer portal, past the firewalls that exist to protect patient information, and delve into the databases of hospitals, physicians' offices, clinics, long-term care facilities, nursing homes, pharmacies, and even insurance companies. And you can go through the electronic data, and again, because the data is typically coded, you can use standardized coding systems or schemes to capture information about diseases, about procedures, about medications. And you can take that information back through your firewalls and through the portals and put it into a common module, if you will, or language, so that the data is standardized, okay? And then you can start to analyze it, and you can look at patient outcomes. And what the Food and Drug Administration is hoping is that they create enough of these coordinating centers that they can start looking at information in different settings and be able to determine whether they truly are getting the outcomes of that they had anticipated. That information comes back to the Food and Drug Administration, and then they immediately share it not only amongst themselves, but people in the industry, including clinicians like us here at the hospital, patients who are the objects of these products, and then certainly the industry for those vendors that are making the products. So this has become a standardized platform now. Recognize that there's been a huge push by the Obama administration to foster the use of electronic health records, and one of the reasons for this is to be able to process data and analyze it. Okay. Now, you would think because we have access to computers that this becomes really simple, but it's not. Okay, and I will tell you that we are in the infancy of analyzing medical record codes here in the United States. We're in the infancy of touching or delving into databases, and the question obviously is, do we have the right information? Do we have all the information we need? Have we made sure that there aren't errors in the information as we move forward? So on this slide, you'll see that, as I've suggested, that we're still early on in this and getting good quality data. The data is often not complete, and many of the settings are not in an electronic format. I can tell you that data is often missing, so something as simple as a patient weight that we hope to capture at every encounter may not be recorded. Certain laboratory tests may not be recorded, so that's a problem. The severity of illnesses, you can code somebody to suggest that they have something like heart failure or have something like atrial fibrillation or they have something like respiratory illness, and the severity clearly is not captured in a code. The event descriptions that occur in the data world may not be the same as what you see in a randomized controlled trial. So if we do an ultrasound, a venography to detect deep vein thrombosis, we may find events that are both symptomatic and blood clots that are asymptomatic. If you are coming into a clinic and you are asymptomatic, there is no way of us detecting whether a blood clot is present. And so it's hard to judge the frequency and the impact of events like that in real-life databases. And then more importantly, some of those events may not be significant either. And if you're detecting them and they're not important, if you don't detect them and they are important, you may end up with comparisons that are basically apples to oranges. And so that's the tough part about coding. You need to have manpower to do this. You need to have computer wizards. You need to have statisticians. And I think, again, we're still learning at that as we go forward. And again, I've mentioned the different degrees of severity of condition, and that's not as obvious in terms of treatment. And then finally, the world is a small place. I know many many of the physicians I work with travel around the world to see patients, and the practices and the information that is collected. So treatment patterns, the outcomes that are measured, the comorbidities may be different from area of the world to area of the world. Okay, so I think that's the intent. So clearly differences in terms of looking at medical record codes versus what we capture in a randomized control trial. So I've put together some examples here. I said I would touch base on studies that examples, so this red arrow should be here. So let's talk about some examples of real-life trials comparing NOACs to warfarin and NOACs to NOACs, and then we'll finish. So I mentioned the Mini Sentinel project, and again, the FDA carried out 2 pilot projects when the drug dabigatran was released. So if you remember, when the drug was first released, they did a Part 1 study that was posted on their website. They looked at a health claims database, and so they looked at patients who had atrial fibrillation from October of 2010 to December of 2011. They captured 22,000 patients that were new users and 44,000 patients that were new users of anticoagulation with atrial fibrillation. And then they looked to follow patients to see what the rate of gastrointestinal hemorrhage and intracranial hemorrhage was from both inpatient and emergency room settings. Okay, and the suspicion when this trial went forward was that the dabigatran was associated with a higher rate of bleeding episodes than the conventional treatments of warfarin. And as it turns out, in this database, that was not the case. In this graphic in the red, you can see the incidence of both gastrointestinal hemorrhage, all events, and then broken down by age, intracranial hemorrhage, broken down by age. And the 2 different categories, so 22,000 patients with pre-existing AF, 44,000 patients that were new in terms of treatment. And again, the rates of bleeding events were statistically lower with dabigatran in both of those categories. Not that that was enough. They did a second follow-up study, again, looking at just elderly patients now over the age of 65. There were 67,000 patients in each cohort. Again, new users of anticoagulation in the setting of atrial fibrillation. This time, they looked at stroke, intracranial hemorrhage, gastrointestinal bleeding, acute myocardial infarction, etc. And I think the point here is when you looked at dabigatran, the rates of ischemic stroke again were lower with the use, and very, very comparable with the clinical trials in terms of using dabigatran. The gastrointestinal hemorrhage again was higher than what was seen with warfarin, so a higher rate of intestinal bleeding. But again, when you looked at the rates of the trials compared to warfarin and what was accomplished in the RELY trial, again, not much of a difference. So what's my point here? My point here is through the benefits of electronic records, the FDA was able to look into the databases of both hospitals in emergency room settings and look at patients that had bleeding events and stroke complications. And what they found was that at least in the electronic world of routine care, again, real-world studies of routine care, the drug dabigatran performed very much similarly to what was seen in the trial that got its approval, the RELY trial, so atrial fibrillation. Okay. Now, as you would suggest, and I put this up here so you could see the different codes. So these are the the codes that are used to depict things like atrial fibrillation and atrial flutter and mitral stenosis, etc. The codes that are associated with stroke and the codes that are associated with hemorrhage and gastrointestinal bleeding, and you can see that there's quite a few of them. The point here is that, again, we're relying on codes to basically dredge data and come up with a picture of how well we're performing. And there are some important points here that I think outline the limitations. So, the question is does this represent the general population? And there were differences in terms of gastrointestinal hemorrhage in the first part of the study. In part one, the patients were certainly younger. Okay, we'll talk about matching principles in a second, and matching is always difficult in the electronic world. There was no access to laboratory trials in terms of whether these patients had renal dysfunction or whether they had hepatic dysfunction. And so the quality of identifying those patients wasn't exactly perfect. We certainly didn't have information on some of the over-the-counter medications, and those become incredibly important because aspirin raises, if you take aspirin, it's going to raise your incidence of bleeding. And then a number of patients only got one prescription and never went back to their pharmacy. So there were clearly deficiencies in terms of the electronic records that may lead you to believe whether they're believable or not. Okay? So that leads us to a couple of recent studies, and I thought I picked out two. So that was the study that compared dabigatran, a novel anticoagulant, to warfarin. I wanted to pick out a couple more trials because these came out in the last year. And in this trial, this was a comparison of dabigatran and rivaroxaban in patients with non-valvular atrial fibrillation. So let's find the codes for atrial fibrillation and atrial flutter. They were able to identify whether patients got a prescription for either dabigatran or rivaroxaban, and they carried out the study between November 2011 and June of 2014. And it's pretty easy. So every one of these diseases has a code. The drugs have a code, and we know when patients receive them because the information is passed electronically to the government. And so we capture this with non-valvular atrial fibrillation. So let me walk you through the logic here. So this information, again, was electronic in nature. They looked at Medicare beneficiaries, so anybody that was in Part A, the hospitalization coverage, Part B, which is outpatient care, and anybody that got Part T, which is prescription drugs. They were able to identify the codes for atrial fibrillation and atrial flutter. They were able to identify whether patients got a prescription for either dabigatran or rivaroxaban, and they carried out the study between November 2011 and June of 2014. And it's pretty easy. So every one of these diseases has a code. The drugs have a code, and we know when patients receive them because the information is passed electronically to the government. And so we capture this big population of patients. They excluded anybody that was enrolled less than 6 months in Medicare. They excluded young people, so anybody under the age of 65. If you were in a skilled nursing facility, a hospice, or nursing home, if you had kidney disease or kidney transplant, you're excluded because these drugs probably shouldn't be used in those populations of patients. And if you had any type of indication that warranted anticoagulation in the 6 months by going through your records, you were excluded from the trial. Okay? What they looked for is also chronic conditions, okay? Things like heart failure, things like respiratory illness, and you can go through a whole list of inflammatory conditions, but every single comorbidity can be coded and recorded in a record. So they were able to go through chronic conditions. They were able to go through prior cardiovascular conditions, things like hypertension, hyperlipidemia, and they could identify the risks for stroke. And they could identify the risk for bleeding events. And they could identify the sources or your utilization of healthcare resources. And from those records, they could actually create a risk score. So we typically use a CHADS, VASC, or CHAD score for the risk of stroke in patients with atrial fibrillation, or HAS-BLED score for your risk of bleeding. And so through your records, they could actually calculate your scores. All right. Then finally, and this is where it gets a little bit complicated, there are patients that were treated with dabigatran, and there were patients that were treated with rivaroxaban. Now, the problem here is there may have been one of these conditions or underlying comorbidities that forced or led a physician to prescribe one of these agents, either dabigatran or rivaroxaban. And that becomes a confounding factor. And so to try to remove that bias, they used something called propensity score matching, and I'll describe it in a little bit on our next slide, and that is to take away any of the bias that may be present in the selection of the treatment that the physician chose. And again, what this is intended to do is make the populations that receive dabigatran as similar as possible to those patients that received rivaroxaban. So after your propensity scoring and matching, you end up with a population of patients that received rivaroxaban and a population of patients that received dabigatran that should be similar. Okay? So here's what propensity score matching is intended to do. So it's intended to remove that selection bias. So the bias that the physician may have been present, okay, in prescribing one of those agents. And, you know, what was the bias? Well, it could be a comorbidity that was measured, like hypertension or hyperlipidemia. There may have been biases by things like your hair color, your eye color, things that weren't measured, and those would not have been captured, okay? So, again, the intent of this propensity scoring, because we don't have a randomization present, is intended to match these individuals in a way that makes them comparable. And again, so here's the goal, that the individuals who received dabigatran are not different from those who did not receive dabigatran. The individuals that received rivaroxaban are not different than those that did not receive rivaroxaban. So again, this concept of trying to reduce or eliminate any of the biases that are present in these observational studies because we didn't randomize these patients to a specific treatment. Okay. Now, in this study that I picked out, what you'll see here is again, the standard mean differences, if you will. So here's the population of dabigatran patients are patients with rivaroxaban, and if you look, you'll see that there is a zero, meaning that there were no differences between these populations of patients, and they should be nearly identical. Okay? We followed these patients in the rivaroxaban cohort, the dabigatran cohort. Again, there was follow-up on each one of these patients in terms of their treatment. We captured their endpoints of stroke and hemorrhage by using ICD-9 codes, which have about an 85 to 97% accuracy. And we ended up with a population of about 66,000 rivaroxaban patients and about 52,000 dabigatran patients. And what you see is in the results, again, purely observational, in the patients that received dabigatran, if you compare them to those patients that received rivaroxaban, there was no difference in the incidence of thromboembolic stroke. There was, however, a difference in intracranial hemorrhage. So there was a higher rate of intracranial hemorrhage with rivaroxaban, and there was a higher rate of gastrointestinal bleeding with rivaroxaban. Okay? So differences, okay, in that trial. Here's the second trial I wanted to look at. And again, a population of patients that received dabigatran, this time matched to a population that received rivaroxaban or apixaban. They used an Optum, which is a health insurance database. They looked for those patients that had prescriptions for those drugs. They looked for the presence of a code for atrial fibrillation. There were a whole host of patients that were excluded. They looked for the presence of comorbidity so that they could develop CHAD scores for stroke risk and Hasbled scores for bleeding risk. They did the same propensity matching, and they ended up with a cohort of both apixaban, dabigatran, and rivaroxaban patients. There was follow-up again, and just like our prior trial, they looked at ICD-9 codes, or the medical record codes for stroke and systemic embolism and bleeding events. And they ended up with populations of about 15,000 patients of rivaroxaban to compare to dabigatran, apixaban to compare to dabigatran, and apixaban to compare to rivaroxaban. Okay. There's the ICD-9 codes that they looked at from our medical records, folks, to identify bleeding events and stroke events and systemic embolism. Unlike the last trial, there were some differences in the CHADS VAS scoring. You can see there was differences, again, in the populations. Again, were they big differences? No, but there were differences nonetheless. So unlike the first trial, when you start looking at the individual populations of patients, you'll see a difference. Now, what happens in the results? Okay, well, in terms of the outcome of stroke or systemic embolism, this is a hazard ratio. If the red dot falls on one side with the two vertical lines that show our confidence intervals, one drug is superior to another. But what you'll see is they all hover around this central 1.0 mark to suggest there was no advantage in the setting of stroke and systemic embolism. If you looked at major bleeding, again, there was a benefit to the use of dabigatran over rivaroxaban. There was a benefit to the use of apixaban over dabigatran, and there was a benefit to the use of apixaban over rivaroxaban. So slight differences in terms of the efficacy outcome. In terms of intracranial hemorrhage, again, benefit when dabigatran was compared to rivaroxaban, but no other differences between the drugs going forward. Okay, so where do we leave this? All right. There are limitations to these studies. We're taking populations of patients, okay? We are trying to match them on the likelihood of the characteristics of them being prescribed their medications. We don't know if they took their medications religiously. We don't know if they took other medications like aspirin that could have an impact on their event rate. We don't know, and we've been familiar, that there are mistakes made with billing codes, and that is not always 100% accurate. There are a number of other sources of information that are typically not present in these studies, like the severity of disease, the severity of things like renal dysfunction or hepatic dysfunction. And we can't measure those in these electronic settings, okay? So, what do we do with this information? Well, here's my take. There's more and more real-world information that's coming hot and heavy, all right? How do we interpret it? How do we recognize its limitations? Well, I think you have to take this information and rather than use it for an epiphany or illumination, you use it for support, okay? So if you're a physician in a practice setting and you look at a patient and there are certain characteristics that suggest to you, for example, that a patient may be at risk for bleeding and a drug like apixaban may be a better choice for patients, then I think that's what a clinician relies on, that there's some information to help support their decision making, okay? How should clinicians communicate this to patients? Well, I think you have to be very, very careful about promising things to patients in terms of clinical effectiveness, because we truly don't know or have the ability to predict which patients are going to benefit from drugs and which ones aren't. Recognize we are treating huge populations of patients and that many of the events that occur are in small, small numbers, and then difficult to say out of 10,000 patients, which are the few that are going to be the ones that don't have good outcomes versus the patients that seem to do fine. So I think we have to be careful about what we communicate in terms of the results of these trials. And again, I think we use them for support. What do we want the patients to know? I think the patients need to know this information is out there, because without knowing this information, it may be an important element of your own decision making, of whether you want to take a drug that seems to be beneficial in stroke reduction, whether you want to take a drug that may have a lower risk of bleeding, whether you want to take a drug that may have performed well in a small population versus a larger population of patients. So I think that's basically what we're talking about going forward. Do these real-life trials provide information? I think they do. I think it's valuable information, but I think we need to use it for support. And then I think as this technology gets better in terms of information management, and we get better at processing this information, we can use it more and more in terms of our decision making. So with that, I'll stop. I know I went way longer than I thought. So Catherine, do we have any questions coming in?
We do have some questions coming in.
So fire away with the questions.
All right. The first one that we have is, given the volume of data that we have access to, thanks to computers and things like Google, is real-world data becoming more valuable than clinical trial data?
My answer is no, because in our clinical trial data, we have pristine control over the patient and the information that we want to collect. We have done lots of analyses. For example, I use DVT. And if we use electronic health records, you'll find a lot of times there's a suspicion of deep vein thrombosis, but there was never an objective test. And I find it extremely difficult to hang my hat on the suspicion rather than the proven knowledge. So I think right now, if we could, we would do clinical trials on everything. The problem is we don't have the manpower to do it, and also recognize our trials are typically over a short period of time. Usually a year. We can go longer in terms of longitudinal analysis, but recognizing in one of these trials, the average duration of follow-up was only 111 days. So again, I think we follow the clinical trials first, and we use this real-world data for support.
Okay. Another question that came in the study comparing warfarin to dabigatran and bleeding, do you know whether the patients who are on warfarin that had GI bleeds or intracranial hemorrhages, whether their INRs were normal, or were they high, very high, etc.?
We don't know. And this is, again, one of the huge limitations of, we don't know what the history was of the patients taking warfarin. We don't know what their INR values are. And again, Catherine, we've used the HCUP database, for hospitalized patients. There's all kinds of data that's omitted in terms of drug therapy. So the things that you're asking for, I think, is hopefully what will come in the next wave of information. Is it present in our databases? Absolutely. But the amount of laboratory tests that we do and trying to capture that and putting it into an actionable format is going to be difficult. Okay, so that's where we're at. Some of these laboratory tests, a lot of them are not incorporated. I wish we had them.